So great to have you all join us for Tuesday. My name's Michelle Wickie. I'm the Chief Customer Officer at AusMed, and it is my absolute pleasure to introduce Zoe Youl, who is joining us today to speak on creating training plans for specific outcomes. Zoe has over 10 years of experience at AusMed. Don't hold that against her. It's a good place to work. With expertise in critical care nursing, clinical governance and education, she has built an in-depth understanding of the educational and regulatory needs of the Australian healthcare sector. Going to be talking to you about outcomes 5 to 7 today for webinar 4. Welcome, Zoe. Yay!
Woo! Thank you. Thanks, Michelle. Lovely to see you all again. Lovely to see so many gorgeous faces, familiar faces. We have a big one today, so I'm going to get straight into it. Of course, begin by acknowledging the Wurundjeri people. I'm on Wurundjeri land today, and I'd like to acknowledge the influence and ongoing connections that we have towards the Wurundjeri people. Today's agenda, as I said, it's a big one. We're going to start with just a few updates. There's lots in the news, both here and out in the big wide world about aged care and the new standards at the moment. So we'll touch on that first and then go straight into looking at the evidence behind why we need to implement training for 5, 6 and 7. As we all know, standard 5 is a big one. So how I'm going to tackle that is try and look at the clinical evidence base for each of the kind of key elements within that standard. And we'll touch base a little bit on standard 6 auditing because that's a new one, and just finish off with a little sort of big picture view of how we can incorporate mandatory quality indicators into our education process.
Did everyone hear that? Zoe just said a little big picture view. I love it, Zoe. Little big picture.
One slide, little big picture. Significant. There we go. You can hold me to my word. Hopefully I can end on that simple note. So breaking news, all our modules in our Strength and Standards series are now available. So really want to congratulate our education team for putting so much wonderful hard work into getting those first 8 modules live. They are getting very high engagement, being really well evaluated, great reviews, and really want to make sure that you all know about that and start making the most of these wonderful resources. We'll keep you posted as other standards modules are released. As you can see, this is a general module on the standards and then 1 module per standard. As we know, there are other training requirements stemming from the standards, and we're systematically addressing those topics as well. I think we can all probably agree that aged care is in the news at the moment. Clearly, we don't yet have a commencement date. We are certainly monitoring this very closely. You may have seen that the actual period for reviewing the standards guidance material was extended, but it was only extended by 3 weeks. So I'm looking for little clues here and there to try and guess when we might get a live date. We might need to run a little competition, almost like pin the tail on the donkey, guess the commencement date of the new standards. So it is still unclear, but I guess I do just want to highlight a couple of key messages. You can see CEO of Rockpool, Melissa Argent, on the screen. She said at a recent ACPA conference in Queensland, get your ducks in order. Don't wait. Get home from this conference and get your house in order. We can't delay our planning for this. And then some of you, hopefully many of you, had the opportunity to attend either in person or virtually the provider conference in Adelaide a couple of weeks ago. And Commissioner Janet Anderson's message was very similar. Don't wait, get started now, don't slow down. So with that in mind, there are no key changes that I need to announce today in terms of our implementation timeline. It's still business as usual, working towards full implementation and making sure we're ready and we can help you get ready. So no changes here, just really encouraging you that in the months of May and June and even heading into July to make sure you're getting some training underway. That phase 1 general training, for which those modules I've just showed you are absolutely perfect for, will really assist to demonstrate that whenever our go live date is, that you've got an implementation plan in place and that you are one of those organisations that has a plan, you've had a long lead time to prepare, and you're now well on the way to implementing the new standards effectively. Before we get started into the nitty-gritty education, beginning with Standard 5, I just want to, have a moment to really acknowledge that effective implementation of these standards relies on a number of things, of course. We're talking about good processes, good systems, and education. So the systems and processes, they go hand in hand with the education, and we want to be working in the same, dancing almost with our organisation and making sure that the way that we're thinking about preparing for and our timelines for implementing education align with other aspects of an organisation's readiness. So really encourage you to understand, the full picture of how your organisation's going towards implementation and try and align your educational efforts with the other systems and processes in place that are happening concurrently. But as you know, our focus, our scope, our lane is education. So what I want to shift very quickly into now is making sure you're ready to either create training plans and effectively implement education. And let's begin with reviewing our process. So as many of you have heard from the previous webinar and in meetings and calls that I've had with you, this is our approach. We believe that after you've done your gap analysis, you need to have a consistent approach to working out what training, what requirements need to be addressed with training, and or what other activities there are. So we're reviewing each outcome, we're understanding the underlying risk profile, focusing on moderate and high risk, and from there we're able to identify is training required and or other activities. Here's our criteria for classifying risk. You've got high risk. What have we deemed a high risk requirement? It's where that we've got a significant impact to either because of miscare. There is a significant potential for harm to the person, including emotional or psychological harm, and multiple legislative requirements. So this isn't just one line, one word, one action in the standards. We're seeing across multiple legislative requirements that this really matters, or audit evidence. And you've got your moderate risk criteria in orange there, which you can read. I do want to highlight that there are many clinical items from Standard 5 and also Standard 6 that we've actually classified as being high and moderate risk. And that's where we've got a significant impact of harm combined with a sector performance report mention, and it's either also a quality indicator. So there's some big ones coming up, which we'll go through right now. Standard 5 is clearly the biggest. It's the most comprehensive amongst our strengthened standards, and there are significant clinical care requirements to address from this standard. We have a big role to play here. The background to this standard is that it was actually developed by the Australian Commission on Safety and Quality in Healthcare. So that's the hospital regulator. They've written the NSQH standard, so for acute care. So why have we got the acute care regulator that normally regulates hospitals helping us with Standard 5 for aged care? If we rewind, this actually comes from the final report into the Royal Commission, which encouraged that actually this Australian Commission on Safety and Quality in Healthcare be given the responsibility to write the whole of the aged care standards. That didn't happen. It wasn't unanimous in the recommendation, but they did take Standard 5, the clinical care standard, and develop that in partnership with the Aged Care Quality and Safety Commission. So what does that mean? There is a very genuine expectation in this standard to improve the clinical care of older people. And if you can see the small blue box down the bottom here, and you might have seen in the news I think it went live last Tuesday, that we now also have a psychotropic medicines for people with cognitive disability or impairment as a clinical care standard that again was written by the Australian Commission on Safety and Quality in Healthcare. I've included this one. It's a really valuable resource. If you haven't had a chance to look at it, I encourage you to do so. But what this means is that the acute care regulator is getting more and more involved in the regulation and standard setting in aged care, so we can only expect the rigour of Standard 5 to continue. This is what my gap analysis looks like. It's full of red, it's full of orange, and I have been joking to our team in the office that if I was an L&D coordinator, look out, we would be doing standard 5 education for months and months and months. I cannot stress the significance of the need for clinical care education. But where do we focus on? With so many requirements, how do we know, what to address? And we want to focus on preventing harm. Keep it simple. Let's try and prevent harm. Good clinical care education can reduce harm, and this is what improves care. My key point, why I honestly say hand on heart, why there is this need, is because I'm an ICU nurse and I've seen the flip side of older adults with multiple chronic comorbidities that have really acutely deteriorated. They've become seriously unwell. They've perhaps had a preventable hospitalization and often experience preventable harm and sometimes death. And let me tell you, being on the other side where that older adult ends up, I tried very, very hard to provide that person with a dignified death. But getting to hospital and being in a stark, bright, white intensive care unit is very different to the comfort of a home, to a residential environment where we can provide a comfortable, dignified death. So that is why this really matters. Good clinical care education can reduce harm, and for an older person, that segue of events, that pathway of deterioration is very rapid and does not end well. So that's our role. We want to try and prevent that. That's what Standard 5 is telling us. So as I mentioned, how do I approach that? I'm just going to take my word for it. I want to actually provide you with the clinical evidence base for each of the elements. So each of the outcomes, 1, 2, 3, 4, 5, and 6 for Standard 5. As you can see, this is sort of the template slide that I'll use. And at the top, you've got the summary of the clinical evidence base, which I'll talk about for each slide. But then and I won't call this out every single time, but I draw your attention to the role of the education and the target audience. So this is how I'm trying to make it as practical as possible for you to think about for this particular aspect of Standard 5. What's the key role of education? And what would my target audience be? So who are the people in my organization that might benefit most from this? Now, of course, you've all got different contexts of practice. You've all got different settings. We need to take all of this and apply it to our organizations. But I've tried to, as I said, summarize and give you the why behind the need for education and a little bit of guidance practically about how you can use that. But I do really recommend that, of course, you use your own gap analysis results and assessment to understand, what you're doing specifically. But if we start with a 5.1, clinical governance, with your target audience, you're looking at executive leadership, your governing body members, and maybe your facility managers or, RN. So we're not talking about it for everyone, but the underlying clinical evidence base for clinical governance is that accountability drives quality care. Good governance is vital for effective implementation of all other standards. And particularly when we're working with an unregulated care workforce. Our registered and enrolled nurses have very strict CPD requirements. We've got our May 31st deadline coming up in a couple of weeks where we have to demonstrate, in order to remain registered, that we've done the minimum amount of continuing professional development and documented it. But our care workforce isn't registered. So good clinical governance is particularly important to help us set and identify those scope of practice boundaries, which reduces risk. I'll just add that all of the references will be sent with the slide. So I've got a long reference list. I won't, I won't sort of specifically call out each reference or each paper that I've used for this, but we'll send the slides out and they're there. Moving on to 5.2, preventing and controlling infections in a clinical care environment. This is simple. We've all got the lived experience over the last 4 to 5 years to know that good hand hygiene prevents harm. If we can't prevent harm from happening and an infection does occur, then of course they need to be managed effectively. And that's where our appropriate antimicrobial stewardship comes into play. We want to prevent that resistance. We want to keep our antibiotics working as well as possible. So think about the role of education as being quite practical in nature for your clinical staff. You know, we want hand hygiene, we want good aseptic technique when we're cleaning wounds, and keep perhaps that antimicrobial stewardship and that invasive line management, so an indwelling catheter, tracheostomy, peg tube, so forth. Keep that education up your hand for your senior clinical staff that are actually, managing those devices. 5.3 is our safe and quality use of medicines. Now, this is just a snippet, of course, of the clinical evidence base for why we need good education to prevent harm. And that is very simple. Medicines, what are they? When they're in a little tablet form or a liquid that's been compounded and formulated nicely with TGA approval, they are medicines. But let's not forget, before that happens, they're a drug, they're poisons, and they have serious risks associated with them. So preventable harm, education needs to address the documentation of allergies. We want to be thinking about how do we understand, prevent, and respond to adverse drug reactions. Polypharmacy is clearly a huge topic for our context of practice, and you'll see in a minute the inappropriate use of antipsychotics and antibiotics are defined as a really big risk that we want to mitigate through education when it comes to the quality use of medicines. I want to highlight a key point here though, and that's medicines education only goes 50% of the way. Very clearly in the audit documentation, so the evidence mapping framework is a clear, very clear call to ensure that there are also those effective systems and processes within your organisation that support the implementation of good education. And particularly when we're working with our care workforce alongside our clinical, our RN workforce, is the need to verify scope of practice. So I've taken this specific line directly from the evidence mapping framework, and it says your organisation must have processes to define and verify the scope of clinical practice for prescribing, dispensing, and administering medicines for relevant clinicians. So education goes part of the way. Make sure that that aligns with your good systems and processes to ensure that we do have the safe and quality use of medicines. Next point is that clinical care really has never been more relevant. This is a research article that came out about 2 weeks ago. So just before the psychotropic clinical care standard was released last week, the week before we had this journal article be released in the British Medical Journal. So very high quality literature review. And it was a large study. There were 35,000 older people, so over 50, with dementia. I know that definition's a bit hard for some of us to get our head. I'm just saying that's what the study criteria was. Don't read into it too much. But in all seriousness, what the results of this study showed was that antipsychotic use was associated with increased risk of all outcomes, including stroke, VTE, so that's venous thromboembolism, myocardial infarction, that's a heart attack, heart failure, fractures, pneumonia, and acute kidney injury. So it really does provide new insights into the risks associated with antipsychotics in people with dementia. And I can't stress enough that there is now very good quality evidence that demonstrates the incidence of serious adverse outcomes associated with these medicines in people with dementia. So we need good education, good quality education to prevent harm in this group of people. Again, more evidence for the need for good education on clinical care, in particular the safe and quality use of medicines. This was the latest sector report. So it was data from July to September last year. Medication management was the #1 complaint topic in residential care. So a very high risk area for us to look at carefully how we will address it. The next big one is standard 5.4, comprehensive care. And I know people can find comprehensive care, it's big, but I think what exactly is it? And I encourage you to think about 4 topics to address here within comprehensive care. And they're the words highlighted on your screen here. So we've got assessment, documentation, communication, and deterioration. Why do these matter? So coordinated care, good quality care has to be underpinned by good assessment, right? We need to be able to understand what's an older person experiencing right now. We change shifts. At the end of 8 hours, we've got someone else coming into that role. So we need clear documentation. Not everyone reads the progress notes. You might have a new electronic medical record system. We have language barriers. So of course, communication is the glue that holds that together. And so if we have good assessment, good documentation, excellent communication, what does that enable us? It enables us to recognize and respond to deterioration, and that's what prevents harm and can save lives. So if you think about comprehensive care, boil it down to those 4 things, I think that helps, take the standard and actually think, all right, I get how I can apply this standard in practice. And so this is our bread and butter, assessment, documentation, communication, and I'm in our Melbourne office at the moment, and we've just wrapped up filming another course on deterioration. So absolutely critical. We've got an extensive library of modules on these topics, as you can see in front of you. Again, evidence for good quality clinical care, you just got to go straight to our evidence mapping document. So, that is the document that the auditors will need to use in order to demonstrate, that an organisation is meeting that standard. So for 5.5, there's a very clear message that an organisation is actively addressing these core clinical risks. So what you can see here is provider level and service level evidence that auditors will be looking at collecting. And the key question that they will be asking you and your organisations is, how do you ensure that workers are trained to identify, monitor, and respond to clinical risks? You will be asked to provide evidence. That will be a specific focus of audits, is your response to that question. They have listed the core clinical risks. You can see that's a screenshot right from that evidence mapping document. So within 5.5, we're now going to go through briefly those core clinical risks and demonstrate how we can relate education to those areas. So if we start with choking and swallowing, there is very, very good evidence for education that looks at preventing choking and swallowing. Why? Because a choking and swallowing incident can lead to irreversible brain damage because we've got a lack of cerebral oxygenation occurring. We also have a huge risk of aspiration pneumonia, which is an acute lung infection associated with a choking or a swallowing incident. So there is significant risk associated with eating and drinking and medication administration in many of our older people. And that risk is because of the actual assessed and documented or the potential risk of dysphagia in older adults. But we also have some physiological changes that occur with age. We've got reduced saliva production, and many medications, like anyone that's on a Parkinson's medication or a benzodiazepine, they have additional reduced saliva, dry mouth as a result of those medicines. So For this topic, we not only want good systems and processes in place that captures a person with dysphagia, but we want targeted education. And I do recommend that to your clinical and care staff that are involved in that mealtime experience, to really address this core risk. And you can see some of the AusMed modules that we have on this topic. The next is continence. And I think it's a really important, point to say there is a very strong clinical evidence that preempting a person's toileting needs reduces the risk of harm and increases quality of life. And that's because there's this, what we call a high impact sequelae of events, that if we have reduced mobility, just think in your mind how many of your residents and people in your care meet at least one of these points: reduced mobility, impaired cognition, under or malnutrition, medication side effect, skin integrity or some type of skin breakdown, and frailty. That sequence of events, I call a ticking time bomb. Honestly, that, just think how many residents, meet those, tick those boxes. So that when we have all of those things put together, in the setting of residential aged care in particular, but also home care, we can see a huge cascade of harm occur. The other evidence-based to draw on is the relationship between skin integrity and continence, which I'm sure is familiar to many of you, but we have a very, very, high cost of wound care if we have a wound establish and then break down as a result of incontinence-associated dermatitis. So this all begins with good toileting. We can prevent this sequence of events, by putting good toileting and good continence assessment and management strategies in place. And again, that starts with education for the right target audience, of course. So investing in education here can reduce your costs of harm elsewhere. Good continence education can reduce your risk of falls. Good continence education can reduce your risk of wound breakdown. So, it's an important one, not just to tick the box, but to get right. Moving on to falls and mobility. We know falls are, of course, a significant cause of potential harm, and across, the acute aged community care sectors, they're known as obviously a high priority because there's such a high burden of disease. There's such a high cost associated with falls. Even though we know that education improves care, it can reduce risk, there's still evidence that, good falls prevention education isn't being put in place. So I encourage you to just look at targeted education. Look at your stats. Be guided by your falls rates. Be guided by, what documentation is being presented, and then going quickly with education. So, you might have a general need for falls education, but then you're seeing some rates of higher falls or near misses in certain areas. Use education wisely to address it in a targeted way. And that means, good collaboration with your quality teams as well. The next core clinical risk that falls within 5.5 is nutrition and hydration. Now, we've obviously got standard 6, the new one on nutrition, so I'll cover this more in a couple of minutes, but I do want to just highlight, the need to not overlook hydration. Our fluid status or dehydration is directly linked to our risk of pressure injuries and is a leading factor in UTIs, urinary tract infections causing. There's a lot of integration of risks associated with clinical issues. So, and it's because dehydration can, affect our cell turgor. If you think of, when you're dehydration, you've got something called a snuff box here between your thumb and your index finger. If you push that, when you're dehydrated, you know, there's not a lot of turgor in your skin. And then if you think of the older people in your care and you go and shake their hand and say, you know, how you going? How, you know, feel their hands, often dehydrated. So we're still seeing dehydration in older adults, but education is a powerful vehicle for resolving this. But you put that with the previous slide on safe swallowing and choking. Clearly, we need education to make sure that our staff understand the risks associated with drinking a particular fluid in a particular person, and they don't just hear the message, you know, hydrate, hydrate, hydrate. So, you know, the more we talk about it, that the more there is to, you know, to really get right. It's non-trivial, the amount of clinical risks in older people, particularly when we've got chronic comorbidities, we've got frailty, we've got dehydration. You know, there's a lot to manage. When it comes to mental health, I guess I'll just use this as a quick opportunity to say that from a training perspective, I guess it's an opportunity to incorporate a couple of core topics with mental health. So you can see, you know, we've got a module on cultural safety in mental health, or trauma and mental health. Mental health is such a big topic. We could have a whole other webinar on mental health. But, you know, use some of these AusMed modules wisely to think about, you know, how can I reduce the risk of mental health deterioration? So we're talking particularly, you know, depression, anxiety in an older adult, in a culturally safe, trauma-informed, healing-informed way. And so there's some, you know, really, really great, well-made modules that can support you with that. Oral health, again, we know this is particularly important, not just for our quality of life, but for our general health. And in our population, older adults are less able to self-manage their oral health. So, you know, good education aimed at our care staff that are primarily involved in this particular area of care is critical. Pain management. I mean, anyone that's had pain, it's awful. Acute pain, chronic pain, acute on chronic pain. We're talking about a complex topic. And, you know, I think it's really important to emphasize that for this particular topic, we do need different modules to target our different target audience based on the complexity of that role. So we've got different you know, different duration modules, different types of modules. You might have an 8-minute brief article, or, you know, our pain management course is, I think, about 45 or 50 minutes. And I'd be aiming that at your registered staff. So, you know, clinicians, registered, you know, registered nurses, enrolled nurses, and your care staff, we all play a really critical role in identifying, assessing, and managing pain. But understand the way that this is done in your organisation and the different scopes, so that you can then identify what education, what module might be most relevant to the various target audiences. All right, pressure injuries and wounds. I think every time I teach this topic, I'm sorry for the you know, the very visual image here, but I remember the really bad wounds that I've seen. I worked in oncology, hematology, palliative care, neuro, ICU, and I've seen some bad wounds over time that should have been prevented. The cost of managing these is incredible. The cost to the person, if you've ever been with a person with a fungating wound, so that's a wound that smells, you can see, you can feel, you can hear the impact that that wound has on that person's sense of self and quality of life. Wounds aren't just costly in terms of dollars, but they really can impact a person's sense of self. You overlay that to an older adult who's already, you know, grieving, feeling a sense of loss, transitioning to a new, you know, a new environment, has a form of cognitive decline. Adding a wound onto that, you know, pain when they're unable to communicate. It's a lot. to our most vulnerable. So we really, really want good prevention strategies, good documentation that aims at minimizing a person's risk, because early recognition of an early pressure injury and preventing that deterioration, that even hospitalization or that unnecessary and costly wound care really does reduce harm. So if you're looking at, how you can go about addressing this particular requirement, I'd probably split it up into your prevention and your management, and perhaps look at a training module that focuses on prevention to your care staff, and that more in-depth management, so your wound selection for, some of your clinical staff. If you know this, if you know the importance of good pressure injury prevention through education, look away now. I give you permission, look away now, full disclaimer, but this is what good wound care education looks like. We stop bad stage 4 full thickness tissue loss from occurring. That is what good wound education looks like. That's the worst of the slides. So I'll swiftly move on, but it is important. Once you see that, you can't unsee it, and that image will stick with you. All right, sensory impairment. This is clearly a huge topic. It's the last of the, the final component of 5.5. So we're nearly towards the end of standard 5. But, I think, something I want to highlight when it comes to sensory and cognitive impairment is, I really urge you are leaders in your organization in a really quite a powerful position, where you can make decisions about what education you're going to invest in. When it comes to dementia, delirium, behavioral disturbance, cognitive impairment, I really encourage you to think about how we can help someone understand the importance of having a person's unmet needs met. I'll kind of unpack that a little bit. If we can understand, or if through education we can help others understand, that often basic unmet needs of an older adult with cognitive impairment can be that cause of deterioration and acute behavioral deterioration, we can totally, reshape the way that we support people with dementia. So, thinking about that, if we understand, what are the core needs that an older person has, and if we can work out for each person in a person-centered approach how we can identify and respond to those basic needs, then we can often minimize situations that may precipitate changes in behavior and those difficult changes. So invest in, really core basic education. There's some great modules that we have on it that help us look at dementia and delirium in a different way, a person-centered way. What are the needs of the person in this situation, rather than, an immediate response to a deteriorating behavior? So there are many, many more high-risk clinical needs. The good news is that there are many AusMed modules available to help you reduce this and address these requirements. Clinical care is our bread and butter. We actually, many of you may know this, but we started as a publishing company. Our founder, Cynthia, is a nurse, and she wrote the first book on the first AusMed book on managing urinary incontinence in the older adult. So clinical care, and particularly in aged care, has been our bread and butter. So I really encourage you to explore the library if you've got access to it, and really look at, the huge variety. I haven't even mentioned the word diabetes. And you think about the risks associated with a hypoglycemic episode. So the risk of insulin, the risk of asthma. We haven't covered anything to do with stroke, chest pain. There is a lot of clinical risks out there, and I encourage you to look at your organisations, your gap analysis, and identify if there are some risks within your organisation that you might like to look at mitigating through education with our modules. All right, little pause here. That was the big one done. Well done. We'll move on to standard 6. It's a little bit of a somewhat lighter topic, but you know, I won't you know, say it's an easy one. I think there's a little bit of depth to it that's important to take note of. It's a new standard, of course. So even though we haven't had these finalized, because of the delay in the commencement date, we anticipate that you know, standard 6 is only going to be available for our category 6 providers, so residential care. If you work in home care, standard 6 and 7 at this stage aren't applicable, but I think everything at the moment has a little asterisk on it. But with standard 6 food and nutrition, as you can see on the left in orange, we've identified 3 moderate risk concepts, and they are the assessment of nutritional needs and preferences, menu planning, and creating an enjoyable food, drink, and dining experience. So the rationale for why those 3 are listed as moderate is because of their relationship to, I think there's 4 key national mandatory quality indicators: the consumer experience, activities of daily living, quality of life, and unplanned weight loss. Those 3 all relate to that quality indicator, which, if you think back to our classification of risk at the beginning, that's where we you know, made this assessment from. As you can, you know, probably put the pieces together and are well aware by now, when it comes to the high risk item of texture modified diet, that's because of the significant harm associated with dysphagia. So it's a safety issue, which is why I've put that as a high risk requirement. You know, tapping into that a little bit, I think, you know, we've touched on it already, but you know, someone with dysphagia may experience coughing, gagging, choking when eating or drinking. And so, you know, there's specific mention of dysphagia in the evidence mapping framework, where an auditor will be instructed to ask about how an older person that's at risk of choking is provided with support to eat and drink safely. So, you know, that they will be asking staff, how do you support these people to eat and drink safely? We want to make sure that any staff that is, you know, involved in that that mealtime experience understands the risks associated with dysphagia and the role that a texture modified diet can play there. So here's our corresponding modules, most relevant to standard 6 food and nutrition. I've marked nutritious drinks and snacks as something that we don't have a module on at the moment, being very transparent and saying, you know, we are working towards, you know, filling any gaps in our library, you know, based on our gap analysis. So there may not always be a direct resource, but often something like that can be met indirectly through another module. And again, a reminder here, I've put fluid in there because, as I've, you know, touched on already, you know, understanding good fluid balance, safe hydration, and assessment of some of those risks associated with dehydration really can prevent harm. So what I mentioned just at the start about, you know, not taking standard 6 too lightly, you know, I know we can often look at some particular standard and think, oh, that's pretty good. Yeah, I think that, you know, that's not too bad, that one. You know, I just want to highlight that there is some critical importance involved in the training of standard 6. And I encourage us all to move, I guess, just beyond just food. You know, when I look at standard 6 through the lens of, you know, intensive care, clinical care, where's the risk, where's the harm, I think about it as a high risk, high impact requirements sit within standard 6. So we have significant health risks and complications that can come as a result of poor nutrition and poor hydration. So malnutrition has severe health complications. Dehydration leads to an increased risk of pressure injuries and UTI. A choking incident really is a preventable hospitalisation. You know, we may need to send that person to hospital as a result of a choking incident, or at least administer, you know, some pretty full-on first aid. But we would want to be ensuring that there's no aspiration pneumonia. That's often a transition of care to a more acute environment. And again, your dysphagia, you're looking at urgent first aid. So within Standard 6, you know, really look at how we can use education wisely to safeguard against some of these more serious clinical risks that genuinely can come from nutrition and hydration concerns. How do we achieve that? You know, as I said, there's a little bit more to it. I think, need to look at that role specific training. It's not a spray and pray. It's really identifying, you know, based on the risk and your target audience within your organization, who needs what. So your clinical staff, you know, education there can focus on that, recognizing and responding to an emergency and escalating care, those more complex high risk residents. Whereas your kitchen staff is around that food safety and handling, understanding, you know, how we create those beautiful meals and menu planning. So, you know, even though there is some, you know, risk associated with our Standard 6, the way that we approach it can very much be, you know, through different role specific training. A quick look, because it's new, you know, what auditors would look for. I've touched on it slightly. And it won't be a surprise, you know, anyone that's done, you know, many of these, you know, webinars already will know that there is as much of a requirement for education as it is for good systems and processes. And that's really evident when we look at the audit requirements for Standard 6. There is a really heavy focus on developing and implementing systems and processes for food and nutrition. In terms of the evidence that auditors will look for, you've got a table, you've got documentation, evidence of engagement, and evidence of continuous improvement initiatives. So you can see what's highlighted. In terms of documentation, you might be asked to provide sample menus, charts. In terms of engagement, you know, the Commission really wants to see active partnership with older people in terms of menu planning, and of course, integrating feedback into that process, and, you know, popping that evidence of feedback or a complaint directly into a plan for continuous improvement, you know, will demonstrate that we're actively responding to that feedback and incorporating that into our service design. All right, we're almost there, going well for time. I'll briefly touch on Standard 7. Again, keeping in mind our service categories. At this stage, it looks like, of course, this is only relevant to the residential community. I'm just saying asterisk because, you know, we may see some changes, but I think it's pretty certain to say that, you know, the three moderate risks that we've identified from Standard 7 directly relate to some of our key mandatory quality indicators. So the rationale for training here in Standard 7 is that if we can minimize something like you know, boredom and loneliness, then we can hopefully see an increase in some of that QI data relating to consumer experience and quality care. Lots of AusMed modules corresponding to Standard 7, range of formats, and of course, you know, a really important opportunity to make sure that education here aligns with other initiatives within your organisation. So whatever your leisure and lifestyle and other teams are doing is obviously critical. All right, so we're almost there. I mentioned at the start, you know, the relationship between quality indicators. So take a screenshot here if you like. But what I wanted to present here, just to finish up with, is that I know we've covered a lot of requirements from the standards, you know, 5, 6, and 7 today. And then in last month's webinar, we covered a lot of requirements stemming from 1 to 4. You know, we have assessed a high, you know, need for education that stem from these new standards. But I wanted to end with this slide to show you that We can use mandatory quality indicators to prioritize and then go on to measure education. So how? Well, what you see here is that, across the 7 standards, for each standard, apart from standard 4, we have at least one mandatory quality indicator. So you're already collecting data. Every 3 months, you're already able to access that. You're already able to see, in relation to this mandatory quality indicator, which relates to this standard, where you're going well or what areas of improvement you might need to look at. So I wanted to encourage you to try and tackle education on the new standards by looking at your quality indicator data. Assess which standard, as evidenced by your quality indicator data, where that education is most needed, and look at prioritizing from there. You at least have a pre-education and a post-education baseline to measure its effectiveness and help communicate the value that you and education can bring to your organisation. So just a quick little announcement to end with before we open up for any questions. And it's just we've decided to pause the last 2 webinars in this series until we have a commencement date release. So what that means is, as you can see, they're more practical reporting, adding a competency assessment into your education or combining it into your educational process, because they're much more, I guess, at that pointy end of the doing phase. We think that just pausing for the moment until we've got a clearer indication of that date is the right move. So we've had a lot of registrations already for those webinars. If you're one of them, you'll get an email from Microsoft Teams today just to let you know that the webinar has been rescheduled. So there's no webinar in June, there's no webinar in July. Unless something changes very quickly and we're back on, we've, I think, decided on maybe September, and it's an October date for these 2. So we are keeping a very close eye on the news. We will adjust the schedule accordingly. But at the moment, just pop a pause in the diary for those 2 webinars. As I mentioned, the reference list will be sent out with the slides that we'll send through. It'll be either this afternoon or sometime tomorrow. So there we go. Thank you. That was a big webinar, big meaty couple of standards to cover, but thank you. And I will have a quick drink and then answer any questions if there are any. Thank you.
And then head for a Bex and a good lie down, Zoe. Isn't that what they say? Thank you. That was really informative and nice timekeeping as well, by the way, Zoe. Does anyone have any questions for Zoe this afternoon before we wrap you all up? There's a couple of, so yep, the webinars are posted. Anyone that's registered, whether you've attended or not, will get the link for the recording today. So just, don't stare at your inbox forever, but by tomorrow you'll get a link that comes through. You can rewatch it or find anything that you want screen grabs from. Thanks for the feedback and positive praise. I think praise is always positive. That was like, what do they call it? Anyway, double word. Okay.
Tautology.
Oh, geez, you're all over it. I was going to call that double entendre, and I was like, I'm sure it's not that. Anyway, yeah, all with the words here. Okay, I think the quiet means we are good to wrap you all up. So thanks again. Like Zoe said, there's no webinars in June or July. We will let you know as soon as we've rescheduled that. Keep it closer to the go live date for the standards so that it's really fresh for you guys. And the recordings will come through to your inbox in the next, I'm going to say 24 hours. Austin, you going to nod at me? Oh, yeah, thanks, Zoe. No,
yeah.
Okay, great, perfect.
Beautiful. Thank you all so much. And
thanks,
reach
folks.
out directly if you've got any questions. Always happy to follow up with anyone. So we'll look forward to hearing from you soon. Thank you.
Bye.
Thanks, Michelle. Bye-bye.